Okay, so my case study was blood flow restriction rehabilitation. The purpose of my case is to see if blood flow restriction or BFR had a significant impact on rehabilitation for lower leg injuries versus just a standard rehabilitation with no BFR. The patient that I followed is a 37-year-old female, chief complaint of intermittent mild left knee pain for the past 2 years, which recently increased and became persistent in February of 2020. She first noticed it after a long flight. There's no mechanism of injury, although the patient attributes to excessive skiing. The medical diagnosis from the referring physician was left knee pain, left thigh muscle weakness and atrophy, articular cartilage tear, or OCD. The patient first came to therapy because they wanted to have pain-free and knee extension, improve strength in knee extension, have no pain in the knee while sitting, and improve their hip strength. Those were some of the goals that the patient and the physical therapist discussed in the initial evaluation to determine what the patient wanted to get out of rehab. After asking the patient about other pertinent information, we found out the patient had injections 2 years ago, is a recreational skier. Moving her knee after prolonged periods of immobilization aggravated her symptoms, like getting out of bed, standing after sitting for long periods of time. And she's a frequent traveler, so after plane rides, her pain scale at baseline was a 2 out of 10, but when it was worse, it was like a 5 or a 6 out of 10. After evaluating the patient, the provider suspected a possible ACL tear, left anterior medial knee pain that radiates to hip, and the patient was sent for imaging for x-rays and an MRI. The x-ray showed no significant findings. They did standing AP, lateral tunnel, and merchant views. The MRI found mild patella alta, mild chondromalacia patella, and mild Hoffman's fat pad impingement. And other than that, everything else seemed okay. The grade level for hip manual muscle tests and knee manual muscle tests, you can see we're a little bit lower. So that was kind of what we wanted to work on. Throughout the patient's rehabilitation program, we were able to bump up exercises to increase the level of difficulty. And with BFR each week, we bump up the percentage of restriction. We start at usually occluding 60% of blood flow and go up to 80%. By the patient's fifth visit, they had already progressed to 80%, which is about 2 weeks into it. After her most recent visit, we had to hold off on BFR due to other medical conditions. The doctor advised us to stop until it was resolved. Therefore, we had to change up some of our exercises to maintain the level that they were at before. The patient roughly came for 16 visits. At the patient's re-evaluation visit, they had discussed another 2 times a week for 4 weeks, which is about the time that we heard that the doctor wanted us to stop BFR. So we went back to some of the other exercises just to continue her strengthening and gave her a home exercise program. Her anticipated discharge day was April 2nd of this year. And after she left, we went over some of the goals that we had met. And she was pain free during the extension range of motion on that left side. We had improved knee extension strength to a 4 out of 5 on the left side. She reported no pain in knee after sitting for longer than 2 hours. And she was able to negotiate 3 flights of stairs that felt good for her. And again, she was pain free after she left.